I'm very proud and honored to kick off today's programming by introducing Dr. Stephen Ansell from the Mayo Clinic in Rochester, Minnesota. Dr. Ansell is an IWMF trustee and co-chair of the IWMF Scientific Advisory Committee and is a noted WM researcher and clinician. That can't be minimized in any way. While he's been with Mayo since 1999, his research into WM over the years has been insightful and groundbreaking. And we look forward to more exciting research findings on the part of Dr. Ansell and his colleagues at Mayo in the future. You can learn more about Dr. Ansell in his bio, and it's one of the resources that are available for today's program on the IWMF website. Dr. Ansell will now present to you a concise and informative review of current treatment options, immediately followed by a question and answer session after he's done. Dr. Ansell?
All right, so my charge today was to talk about current treatment options for Waldenstrom's macroglobulinemia. And I really do hope that as you're participating in this education forum, there'll be lots of other pieces of information that will complement this. So I've tried to stay kind of pretty much focused on just a few reminders about Waldenstrom's, focus on clinical studies and clinical results and a strategy for managing patients, and then specifically really get questions and feedback and comments, because again, I think the goal of any forum like this is to make this as valuable as possible for patients. So as I said, my charge today is to talk about current treatment options. So in essence, what I'm going to talk about, to stay out of topics that others are going to cover, I'm very briefly just going to remind everybody on the call and watching this, this recording later, what exactly makes somebody have Waldenstrom's macroglobulinemia? What's unique about that? I'm also going to spend a few minutes talking about who exactly needs treatment, because one of the things that you'll hear as multiple people share their stories is that there are times when observation or watchful waiting is very appropriate and treatment isn't needed. Then I'm going to talk about standard treatment options, and I'm going to specifically kind of break it into two parts. If you're newly diagnosed, and I'll stress you need treatment, what treatment should you get? And then if you have relapsed disease, what are the options? And there'll be more information related to that as we go through, and I will just address that at a high level. So as we start off, I think it's really important to remind ourselves what exactly Waldenstrom's macroglobulinemia is. And the reason that's important is comments have been made already this morning that it's a rare entity, and often, as I say, there can be some debate and discussion about whether or not one actually has this diagnosis. So many will know that I've said this before, but I do think it's really important to remind us that Waldenstrom's macroglobulinemia is a disease with two distinct problems. The one problem is a lymphoplasmacytic lymphoma, and that is really a cancer, a malignancy of lymphocytes. These lymphocytes are stuck in the process of going from a lymphocyte to a plasma cell, which is what they would normally do when they're exposed to foreign proteins. And as they do that, they are making antibodies. But as they go from a lymphocyte to a plasma cell, that's where the lymphoplasmacytic lymphoma comes from, if a genetic error is made, and that kind of jams the cells up in this process. The reason this is important is these cells now live longer than they should. They may not necessarily grow faster than they should, but they certainly live longer than they should, and they won't die off like they are meant to. So because of that, they start to accumulate, and places they accumulate are commonly in the bone marrow. That's why bone marrow tests are very often done. But it can also be in other places like lymph nodes, sometimes in the liver and spleen. And as you just heard in the case of Bing-Neal syndrome, you can actually get some involvement even in other tissues, including the CNS or the brain area. So this infiltrate can cause problems by having low blood counts, enlarged lymph nodes, and challenges with different places where these cells are kind of taking up space. The other side of the whole process is this monoclonal IgM protein. And I show this here in a cartoon fashion, but what's really important about it is the size. It's really 5 antibodies all stuck together. That's what makes IgM. And it's a big molecule. And not only is it a big molecule, it's a sticky molecule. So because of that, it can stick many places or clog up different places, causing problems. So this hyperviscosity issue that you hear mentioned, the visual challenges, the problems with deposition and stickiness when it touches nerves and causes neuropathy, or when it gets into tissues, causes things like amyloidosis, or if it actually kind of sticks to red cells and causes significant hemolytic anemia. So a disease with two problems, the cells and the protein. This just is what it looks like inside the bone marrow. And you can see, remember I said lymphoplasmacytic cells. You can see these smaller cells right here. These are the lymphocytes. And these bigger ones here with this kind of light blue stuff around them, these are more plasma cells. And you can see both of these are present. And there are lots of different ways that we would identify these cells. As you're going to hear in greater detail, and probably many of you know, we've also learned a lot about the genetics of those cells. And we've learned that mutations in, for example, MYD88, which is an adapter protein, that is a protein that regulates messages that come from the outside of the cell to the inside of the cell. And when that becomes mutated, it begins to amplify the messages. And in amplifying the messages, causes really the cell to become hyperstimulated and makes it grow. You'll also know that there are mutations in CXCR4, and those actually regulate the ability of the cell to travel to different places. As I mentioned a few minutes ago, that was the cell on the one hand, this is the protein on the other, and the protein is this large protein, and there are multiple characteristics of that protein that really cause the symptoms that we have to deal with when we're dealing with patients, or you as the patient have to deal with. The first thing is the big protein changes the way in which circulation works, and it often makes the circulation kind of thicker, as it were, causing almost a syrupy effect where blood vessels, instead of letting the blood just kind of rush through, the blood is going through in a very thick and syrupy kind of fashion, which really influences the way in which the oxygen is delivered. Then there's this interaction with different tissues, and when that happens, it can stick to things like nerves. And when it does that, nerves malfunction because macrophages, the trash collectors of your body, just come along and eat off that antibody. But when it eats it off, it kind of strips the wiring or the covering to the wiring, causing all kinds of short circuiting, and that's what causes the neuropathy. And then I mentioned at the bottom here this autoantibody activity, and what that means is it's antibodies sticking to self, to your own tissues, like your red cells, and that causes a significant anemia. So what I like to do is just highlight different presentations of different patients. And the reason I do this is to contrast for you that it's really critical as you, the patient or the physician or the care provider, is evaluating the circumstance, that we really understand where in the spectrum of this disease process the patient is. Right on the far left, as it were, are patients where this is an incidental pickup and they have no symptoms at all. On the far side are people that are really sick with cells infiltrating places they don't belong and the protein causing a lot of problems. So here's a 66-year-old patient. This person just went in for an executive physical. He felt in good health. He didn't have any symptoms, but his astute doctor said, you know, you're a little anemic, not all that comfortable about that, and tested blood tests and found that the protein showed that his gamma globulin, that's the immunoglobulin fraction of the proteins in the serum, is increased. Then they'll dive a little deeper and they show that with a special test, it's a monoclonal IgM, and you can see that's 1400 milligrams or 1.4 grams per deciliter. That's a relatively low amount. But again, to make sure that patients have a good understanding of where things are, the physician recommended a bone marrow test, and this showed 20% involvement by a lymphoplasmacytic lymphoma. And a CAT scan was done and didn't show any lymph nodes anyplace. So how does this look? It's a healthy patient, but the patient actually makes the criteria for having Waldenstrom's macroglobulinemia because they have bone marrow involvement by 20% and they have this increased protein detectable. And when they did the MYD88 mutation analysis, it was positive. However, we would call this process asymptomatic or smoldering. In contrast, a similar age patient, and by the way, these are real people, shows up with a lot of fatigue, hasn't been feeling good, can't see very well, very confused and sleepy. Every time he brushes his teeth, he feels like he's bleeding to death because his gums bleed that easily. And his doctor tests and finds that he's pretty anemic with a hemoglobin at 8.8, and platelets are also decreased. He's actually developed an ulcer on both of his ankles. The protein was checked and it's high, and this monoclonal protein in his case is 6.6 grams or 6,600 milligrams. Viscosity test shows the blood to be actually thicker than it should be. That number should be down in the ones, and so clearly he has a hyperviscous process. Has a bone marrow test done. He has lots of bone marrow involvement by that lymphoplasmacytic lymphoma. CAT scan shows he has multiple sites of liver and spleen enlargement and multiple lymph nodes. So clearly two very different patients, both of which would be called Waldenstrom's macroglobulinemia. One patient with no symptoms and really a smoldering low-grade disease, the other patient very clearly ill. So the main question is, where in that continuum does a patient need to be before treatment really becomes the appropriate thing? You could very clearly see here the first patient we would watch and wait. The second patient we would clearly treat, but those patients are far apart and there may be a lot of people in between. This just highlights again some of these issues that we can detect. You can see, as I mentioned, this is a patient that had those ulcers on the leg. You can see them right here. This is called Raynaud's phenomenon on the fingers. You can see these white fingertips because again the blood supply is not getting there because the blood is very thick. This does the same thing on a CAT scan in the brain, and you can see this white areas. This is not normal. Blood flow here is compromised. Patients can't think very well. And here is looking into people's eyes, and you can see this extra red that you can see here is bleeding. And if you look very carefully, and it may not present so well, there's what we call sausaging, where actually the blood vessel almost looks like little blobs of stuff are traveling through because of the fact that the blood is thicker than it should be. This is when I mentioned about how cells stick to each other. What happens then is the macrophages start to chomp up these cells, and you can see many of your red cells are kind of really small compared to the other ones. And these are ones that have already been nibbled on by the cancer, by the macrophages in the patients that have this lymphoplasmacytic cancer. Here you can see what is basically clumping together of red cells. And this is again a mention of how these antibodies are making the red cells stick together. And here is a patient who has pretty significant neuropathy. You can see how the arch of the foot is really kind of pulled up here. This is now an EMG that you see in the middle that shows abnormal conduction. And this on the right is where there is actually deposition of those proteins causing what is called amyloidosis in the actual tissue. So, really important as we start with any decision and discussion about treatment, that we differentiate different types of patients across the spectrum. And you can see Waldenstrom's macroglobulinemia, both the patients I highlighted have that, but you can actually even get a precursor problem called a monoclonal gammopathy of uncertain significance, an MGUS. And then, as I mentioned, some patients have smoldering processes. So I'm not going to go through this in detail, but what I want you to know is there's been a lot of artificial breaking up of these categories to try and put people in different buckets. The first group are the people that have just the protein, but very little in the way of that lymphoplasmacytic lymphoma, and some of them really don't get sick at any point in the future. Others, a little bit like patient number 1 I spoke about, clearly has Waldenstrom's but doesn't need treatment. And then more ill patients that clearly do. And that's a spectrum of disease when you have Waldenstrom's macroglobulinemia or the IgM MGUS that leads to it. So if you were to say, how do average patients showing up, how do they present with symptoms? And this just highlights some of that information. This is a series of 217 patients, brand new. And the point I just want to make here is a quarter of these patients had no symptoms at all, even though they had a pretty high IgM level and a pretty substantial bone marrow involvement. So again, just taking those metrics as the only thing that determines when to start treatment isn't always the best strategy. And that's why you'll see a lot of what constitutes the reason to treat is actually the patient's symptoms. This is why all of this discussion about the IgM-MGUS versus Waldenstroms really matters. Dr. Kyle, as many of you on the call will know, has been someone who's been in this field for many decades, probably 50 to 60 years, and he published information following patients now for more than 40 years. And these are patients that just have the protein, but not a lot of the cells present. We call that the IgM-MGUS. And he looked to see how many of them actually turned into something over time compared to didn't. And you can see here, this is over 40 years. People with IgM-MGUS, only about 15% of them actually turned into something. And so most of the people passed away without evidence of any degree of progression. This was really only a small subset of people. And he reported that the likelihood of you getting a progression to something more sinister if you have this MGUS problem is only about 2% per year for the first 10 years and then 1% per year after that. Why does that matter? We have to be very careful not to tell people they have a cancer when 40 years may go by and they may not actually develop something. This also then shows a little bit more about that, and this is if you're looking at those indolent or smoldering patients and compared to the MGUS patients, again you can see over 10, 15 years, you can see that the vast majority of the patients with that MGUS actually do not actually develop something substantial, and even the people with indolent disease may not have that happen either. So the reason that matters is not to be too quick to treat people who may be well anyway. This actually compares patients with smoldering Waldenstroms to the national average, and you can see that's not actually very different. They may still have problems from Waldenstroms, but they may not have problems more frequently than other people would have problems with car accidents and heart attacks. So again, when to treat is absolutely key. Really treat people only when they need it, not just because they have the disease. So does everyone need treatment at diagnosis? Hope you've already kind of worked out that the answer is no. But who does? And so these are the types of criteria that are typically used to say you really need to get treated. Well, clearly, if your lymphocytes and this lymphoplasmacytic cells are starting to get really active, they can cause a lot of symptoms. We call these constitutional symptoms. And you can see these fevers and drenching sweats and losing weight, not just a little, 10% of one's body weight are all features to suggest the disease is really active. Lymph nodes that are enlarging, spleen that's getting big, again, these cells are now rapidly accumulating. And similarly, you can suddenly get a big drop in the hemoglobin or a drop in the platelet count, and that is because the bone marrow is being filled up by lymphoplasmacytic cells. And then the reason I highlighted those hyperviscosity symptoms and the neuropathy and those amyloidosis and some of those other features, clearly if that's happening, that's impacting a patient's quality of life, and we would very much like to reverse that. That's additional reasons for one to get treated. However, you do not notice here a IgM level, because just the IgM level is not a reason to necessarily get treated. Right as we're thinking about how to treat people, I think the very first question doctors really need to ask is there evidence of hyperviscosity? We touched on this, and that's the visual deterioration, the neurological problems, and bleeding, usually only seen if the IgM is more than about 4 grams. But that is a medical emergency that needs to be treated with plasmapheresis right away, and so just important for people to think about that before jumping in with therapy. This just again touches on some of the symptoms I mentioned. You can see this on the left has got that sausaging situation that I was mentioning. You can see this bleeding that's happening over here where these arrows are, and all of that goes away when you actually specifically treat with plasmapheresis, which in essence is an oil change where we just wash off all that IgM and replace it with saline. So with all of that said, what should be the initial treatment for patients who have got symptomatic Waldenstroms? Hopefully you've realized that we've picked out patients that clearly need therapy, not treating people that have no symptoms at all. We've decided if they needed plasmapheresis and done that. Now the question is what treatment to consider. And really there are a number of different approaches, all of which are highly effective. And I've kind of wanted to put them, I think the top two are the ones that we use most consistently, and the two at the bottom are less so, and I'll explain why. So an alkylating agent is really a chemotherapy which targets the genes and targets the DNA in the cancer cell. And the most typical one there is a drug called bendamustine used in combination with an antibody treatment called rituximab or Rituxan. The second group are what we call BTK inhibitors, and that has to do with the signaling process that comes from outside of the cell to inside the cell through this protein called a Bruton's tyrosine kinase. And there are a number of pills, and we just heard testimony for someone who just got started on it. Again, treatment that is highly effective. Those two classes of drugs are the ones that are most commonly used and are probably the most effective and are our treatment of choice in our practice. A proteasome inhibitor, this is a drug like bortezomib or ixazomib or carfilzomib. Those are basically mess with the protein management in a cell and is an effective therapy in combination. We tend to use that as a second tier, but some groups will use it as frontline. And then in some patients, rituximab is used on its own. We tend to recommend that only in certain circumstances, because many will know there can be what's called an IgM flare, and we want to avoid that if the protein is really high. But this use of Rituxan or rituximab is very useful if you specifically have problems with neuropathy or problems with autoimmune hemolysis, red cell breakdown, and for those specific strategies. As a treatment overall for a patient like we highlighted who would need therapy, we usually do not recommend rituximab on its own. So here's the information to say why we think these treatments are your best choice. This is the study done recently using bendamustine plus rituximab for newly diagnosed patients with Waldenstroms. And what we're highlighting here is the months after treatment was started and how many of the patients are benefiting on the left-hand side. And you can see that right away within 3 months and then finally within 6 months of treatment, the vast majority, and we're talking 90% of people, have had a very good response to treatment with a dramatic decrease in the protein, a clearing out of the cells, and a decrease in lymph nodes if they had that. One of the reasons in our practice that we tend to favor the bendamustine approach is on the right here, and that's because it doesn't actually matter about the genetics. All the groups of people, whether they have the MYD88 mutation or a CXCR4 mutation, doesn't matter. Pretty much everyone has a similar benefit from therapy. The second group of drugs, as we touched on, was this BTK inhibitor. The big advantage of this therapy is it's a pill compared to an intravenous treatment with the bendamustine plus rituximab. Again, what I want to highlight here is you can see the same thing, the number of rounds of treatment, so this is pretty much the months, and the number of people that have had a really good response. And you can see that right away, within the 2 to 3 month period, there is a significant percentage of patients that are responding to treatment. And this treatment response is very durable over time. What is a little different is the pace of response based on this CXCR4 mutation. So sometimes you'll hear people say that they don't respond quite that well. I don't think that's entirely accurate. If you look at this information, you can see that you just have to wait a little longer. Because when you're looking out here at about 12 months, you can see most patients, regardless of whether they have that mutation or not, are still benefiting from treatment, but it took longer for that to occur. But ibrutinib is a very effective therapy for patients in frontline treatment. Here is information now about new generation BTK inhibitors. This is a drug called Xanabrutinib. It's the second generation ibrutinib, if you like. And this was a randomized comparison of the two drugs against each other. I think the important thing to say here is that the overall response rates looked very similar. I think what's different though is the side effect profile is a little different. You can see here ibrutinib has a little bit more of the irregular heart rate kind of problems and maybe a little bit more bruising and bleeding, whereas Xanabrutinib has more in the way of lower blood counts. So I think it's a little bit of picking your treatment based on the patient specifically. All told though, I think both of these are highly effective agents. We mentioned this bortezomib or the proteasome inhibitors, and I just wanted to highlight here that again, this is a very effective therapy. You can see this is what's called a waterfall plot. It shows that the vast majority of these patients clearly benefited, and they benefited in a similar, very rapid response fashion with a very high percentage of patients having benefit. So all of these are very effective therapies. The Xanabrutinib is the other one. So bortezomib is one of the proteasome inhibitors. This is Xanabrutinib. And all again I want to highlight here is that there is a high response rate in the majority of patients. I touched on this a little earlier, and this is the rituximab alone. Just to point out that 4 doses of rituximab gets a response rate of about 50%. It's a little lower than the others. And I mentioned the flare phenomenon, which is really seen in the majority of patients. And interestingly, it can persist for many months. So again, we recommend rituximab in a more kind of select population, particularly those with nerve problems or hemolysis. So here's an algorithm that we tend to kind of consider. The first question is, does a patient need treatment? Yes or no? If not, they have either smoldering or IgM MGUS and really should just be followed. And we recommend a recheck every 3 to 6 months with that protein being monitored. However, if the patient does meet criteria, and remember we mentioned those are listed here, then we say, does the patient have hyperviscosity? And if yes, they really need to get right away to plasmapheresis. But if no, then are they fit for chemotherapy? If they're younger patients, reasonably fit, and really most patients can tolerate the therapy, we consider the bendamustine rituximab combination for 4 to 6 cycles. On the other hand, if the patient is older, taking a lot of other therapies, would prefer a pill approach, then the BTK inhibitor is the preferred route. This one is a finite amount of treatment. This is a long-term, everyday kind of treatment. So this just highlights that consensus. We try and break apart the IgM MGUS and smoldering patients because they get observed. The ones that have the neuropathy or hemolysis and others, they're the patients who get rituximab alone. And then the patients who need treatment get bendamustine plus rituximab, or alternatively, the BTK inhibitor. So very briefly, just as I end, wanted to talk now about subsequent treatment for patients who have relapsed disease. One of the things that's highlighted here is that inside the cell, there are many potential vulnerabilities. So I don't expect anyone to understand or pick on all of this, but all I wanted to highlight was all of these boxes are different ways in which you can mess with the cell which needs that, the cancer cell, and thereby create effective treatment in patients who relapse. This just shows you that another one of those BTK inhibitors called acalabrutinib was tested specifically in patients who had relapse disease and published recently. Again, I just want to point out the high percentage of patients that benefited from this therapy. This is treatment for another agent. This is one that tips the balance in direction of getting the cells to die. Remember I said it right at the beginning, the cells don't die very well. It's called Venetoclax. And you can see again, a very high percentage of patients benefiting. And this is a waterfall plot showing that most patients benefit from this treatment. So just to give rather than get deep into every single type of treatment, we just wanted to highlight here, when you have a patient who has relapsed disease, the first question comes back to where we were before. If the patient doesn't have symptoms, you may not need to treat right away. And we watch the patient until these types of symptoms start to show back up again. If that's the case, you can see a variety of different options that are needed or considered here. Other of the BTK inhibitors, the bendamustine if they didn't receive it before. Sometimes there are other chemotherapies. If the patient really had a very extended period of benefit from treatment and then it was stopped, we'd consider retreating, or the use of bortezomib, and in rare patients, sometimes a stem cell transplant. This just very briefly talks about stem cell transplant, some series that have shown that it can be very effective. You can see that patients needing that remained in remission at 5 years, about 40% of them. Autologous transplant, if we're doing a transplant, is what we consider. Allogeneic transplant is also reasonable, but has a lot of side effects and a great risk to the patient, so we tend to really limit that. And then finally, an exciting area that's developing and could be the future are CAR T cells. These are where we take your T cells out of your body, we engineer them to stick on the tumor, we really kind of turn them into an activated cell. Very few patients have been treated with Waldenstroms, but marginal zone lymphoma is a close cousin, and you can see a very high percentage of patients that have benefited from this particular type of treatment. Does have a lot of side effects. That's one of the reasons we wouldn't do it right away. Can cause all kinds of issues, which I won't go into now, but it's still a very promising treatment in patients who have very tough to treat disease. So with that, I'll thank you very much for your time and attention. I'm going to end here, and I'll be very happy to take any questions or comments or anything, Pete, that you'd like to address. Thank you.
Okay. Thank you, Dr. Ansell, for taking the time to speak to us, especially, and also to present your perspective on the various treatment options. Obviously, we've heard many times that the objective is to treat the symptoms, not the numbers, and you keep reminding us of that. And also to go over the different classes of treatments and the fact that every patient is different and every patient is at a different stage of their disease. So it's important to be mindful of that and to be aware of all the treatment options. I recall way back when Rituxan was a new kid on the block and there were only a handful of treatment options. Now it's a much wider array of options that makes it both much better and also more challenging to figure out what's the right one for me. So always consult with your hematologist and also with the experts if you need to, like Dr. Ansell and others. So we'll get into the questions now and kind of go through them as time permits. There are a lot of good questions that are presented. The first one is regards to bendamustine. There are some options available, and their question is, should 4 cycles of bendamustine Rituxan be administered?
Yeah, so this is a good question. You'll see that we said 4 to 6 cycles. And the reason we say that is if one has had an outstanding result after, for example, just 2 rounds of treatment, there is some evidence from a close cousin disease called marginal zone lymphoma that the benefit of only giving 2 more cycles is the same as giving 4 more cycles. So if we have an excellent response, we'll just abbreviate the treatment to 4 cycles. If we've had a good response, but not as good as what we would really want, we'd consider going all the way to 6. And the reason we think about 4 versus 6 is we're wanting to have the best result for the fewest side effects. As we get to the end of treatment, sometimes lower blood counts kind of become more of an issue. And we don't want to just jump right into more side effects without gaining more benefit. So that's the reason to tailor the treatment based on the patient's response.
Thank you. Next question is with regards to post-treatment and how quickly your white blood cell counts return to normal after treatment. This one is particular to bendamustine and Rituxan.
Correct. So this touches on the point that I just made. So this is not as unusual as might have been shared with this particular person. I think one of the reasons we want to kind of trim back on treatment is because there can be a longer term effect on the bone marrow of a drug from like bendamustine. So it's not unusual that it may take many months for the blood counts to slowly make their way back up to normal. And that's why, as I say, if one doesn't need all 6 rounds, because you're having an excellent result, we'll truncate it to 4.
Thank you. This is a question with regards to those wild folks that are out there. What's the preferred treatment for those folks that have that? And would you suggest a BTK inhibitor for someone that is defined or has been tested to be a wild type genetic marker?
So this is a great question. And you might remember when I was talking, I kept on talking about the close cousin, marginal zone lymphoma. So most patients with marginal zone lymphoma are MYD88 wild type. So I'm not saying this person has that disease, but those two are very difficult for a pathologist to tease apart. So that's sometimes why the patients that have Waldenstroms may have some other diseases mixed in, or just be as part of a spectrum, having patients that are this MYD88 mutated versus wild type. So I showed you the information that shows that there are responses, whether you have the mutation or are wild type, to BTK inhibitors. It just takes longer when you have some of the wild type presentation. And probably that's because your disease is a little bit more like the marginal zone than it is like the lymphoplasmacytic. One thing that's important to know is BTK inhibitors are approved for marginal zone lymphoma because they're highly effective. So although you might feel, wow, it could be even better if you have the MYD88 mutation, I would just stress the data would say it's still outstanding. You just might need to be a little more patient. So we would say that if you are using a BTK inhibitor, do not despair, continue on with the treatment. Obviously, if you want to not have to deal with that, the use of bendamustine and rituximab allows you to not need to pay attention as much to that. But my view is that I would be a little cautious not to overplay this as a reason to select treatment. I think it really just informs our expectations of treatment.
Thank you. Yeah, that was, you kind of answered the next question I was going to ask about that, is that, is there a different treatment option that's better for someone that's wild type than a BTK inhibitor?
Yeah, so, I think there are many factors that go into treatment decision making, and that's what I hoped I was sharing. There's how urgently you need treatment, how many side effects and problems you might have, what side effects the drug might do, what are the expectations for benefit and response. But I think if we globally said, what do we expect? We expect that when we treat people who need treatment, predominantly BTK inhibitors and bendamustine rituximab combinations are very effective. And even though there may be some subtle differences in exactly how well people respond, I would say most people will benefit from those therapies over time. If you look at a 12-month endpoint rather than a 3 or 6 month endpoint, the results start to look very similar. So I think this is a decision one makes with your doctor with all of those factors in mind.
Thank you. Next question. Let's see, what's the next question? For someone, regarding the novel agents or the newer agents that are come out there, if someone's currently on ibrutinib, should they switch to Xanabrutinib since the side effects are less, especially cardiotoxicity?
Yeah, so I would say that I would be very careful not to step away, not to take my money off a winning horse. So if you're getting ibrutinib and you're having a great result, and particularly because you're not actually experiencing those side effects, there is absolutely no reason to change your treatment. All you're going to do potentially is just create different side effects, because remember, every drug has its own effects. Now, right at the very beginning, if you're selecting between treatments, you might say if a patient has a known cardiac issue and has had atrial fibrillation and you want to try and minimize those risks, sure, Xanabrutinib may be very appropriate. But again, I want to stress the percentage of people that have these problems are down in the 1 out of 10 range. 9 out of 10 don't have these issues. So I would say if you're currently on a treatment and it's working well for you and you're tolerating it fine, I would not make any changes.
Okay, thank you. And I'm going to throw a little curveball here. I saw a couple questions in the chat, and it has to do with ibrutinib. So it's kind of related to your answer here. With regards to ibrutinib, what's the thought process on how long you should stay on ibrutinib? And also, if you're start out at a 420 milligram dosage per day, can you reduce that over time?
So I think the first thing is, how long should you stay on it? Well, if you're following the chronic lymphocytic leukemia literature, where this is a very effective therapy, there are some strategies that are looking at, can you stop the treatment? However, most of those strategies have combined ibrutinib with a different drug, something like Venetoclax, for example. So it's not really just stopping ibrutinib, it's stopping a treatment package that was really designed to go, for example, for 2 years right from the beginning. So I think our experience so far is if you just stop ibrutinib, generally speaking, the disease comes right back within just a matter of a short period of time. So I would not recommend that as a good strategy. And Pete, I forgot the second question.
The dosage, can it be reduced?
Yeah, and the answer is yes. But the most important thing is, why are you decreasing the dosage? So sometimes we decrease the dose because the patient is having lower blood counts and not tolerating it well. But the dose was designed and developed by looking to see the occupancy of that BTK molecule and maximizing that. Turns out you don't need to maximize it that much, and you can probably get away with less. So often in our practice, if the patient's having some side effects or problems, we'll come down to a lower dose and still see very effective therapy.
Thank you. The next question, we heard earlier when we did the presentation for the volunteer award that Michael Farbman may be facing Bing Neal and treatment for that. So it's kind of appropriate for him also, but it's rare. But is there a treatment option for those that do get Bing Neal syndrome?
Yeah, absolutely. So again, just reminding people what Bing Neal syndrome is. That's where these lymphoplasmacytic cells that we spoke about in the presentation, which can go into lymph nodes and liver and spleen, actually will go into the central nervous system, into the brain or the lining around the brain. And the reason this is an issue is obviously that's not a great place for them to be because they interfere with function, but also they can often hide on the inside or away from the body when it comes to a lining around the brain called the blood-brain barrier. It's like a protective covering your brain has. And not all drugs will actually get right in there to be able to penetrate. So that's why you need to select your treatment well. However, both of the main characteristics, the main groups of treatments that we just spoke about, BTK inhibitors as well as bendamustine plus rituximab, both of them can penetrate and get there, and both of them are effective. I will say there's more experience with the use of bendamustine plus rituximab, but now increasing experience with BTK inhibitors, both actually look quite promising.
That's great. That's good news. Thank you. The next question is probably one you've heard before, but how can patients help educate their local hematologists, oncologists, and nurses about the various treatment options for WM?
So I think this is a very important question, and I often tell patients, and you alluded to the walk for Waldenstroms, it's like you're developing a walking buddy, a running buddy. You want to have a good relationship with your care team and together be encouraging each other around this topic. So if you have a physician who or a nurse practitioner who doesn't know that much about Waldenstroms, they probably know a lot about other diseases that are very similar, and they know a lot about other diseases that are treated with the same drugs. So pointing them to resources like the IWMF, resources like the up-to-date websites and others is very useful, and many of the centers that do a lot of Waldenstroms are more than happy to partner along with local oncologists and hematologists. So I would certainly create a good relationship with your care provider, and then as a team, look to incorporate one more team member, and that might be an expert from somewhere.
Great, thank you. That's very helpful information. The next question is, are there studies that show the difference between men and women in terms of diagnosis, symptoms, and treatment of WM? I noticed there's a couple questions related to this also in the chat area.
Yeah, so in general, this has not been very well or systematically studied. So actually, there's not clear evidence of differences. There are in other fields some differences related to metabolism of, for example, rituximab and sometimes other drugs that may differ between men and women. But most of the time, we are giving such sizable doses of treatment that it overwhelms the differences that are actually there in metabolism and still delivers a very similar amount of treatment. And this disease typically is highly responsive to treatment. So to date, there's not really been a clinically meaningful difference between men and women, outcome, etc.
Interesting. Another curveball here. I don't know if you've ever faced this, but someone asked, like, for women especially, is there a way to distinguish between Bcell symptoms and menopause, night sweats and things like that?
I would tell you that this is probably one of the most common questions that I have to deal with. So this is no curveball at all. So one of the things that's really important is the definition of what constitutes a B symptom or a constitutional symptom, and that is a drenching night sweat. So each of those words are very carefully selected. The sweating is usually at night, not in the day, and drenching in nature means that really you are dripping wet to the point where you have to get up, either change what you were sleeping in or changing the bedding because it's that wet. I joke and tell people it's a little bit like your significant other looks at the puddle that's where your head was on the pillow and goes, "That's disgusting." So it's not like I feel a little hot and sweaty. It's that the water is just running off you. And it's usually at the same time as people are having a high fever, and that's 100 or higher for no good reason, and losing weight. And that's not just a little bit. The pounds are just rolling off. It's 10% of one's body weight. This ends up being not a subtle thing. And so if you're kind of wondering, is this my menopause versus B symptoms? It's probably not B symptoms.
Great, thank you. That helps clarify. Yeah, as someone who had drenching night sweats, I know exactly what you're talking about way back when, definitely. So the next question is regards to the inhibitors. If a patient has been on ibrutinib or Xanabrutinib by itself for years, would it be wise to add a second drug in the hopes that it might delay the development of resistance to the BTK inhibitor?
Yeah, so this is a good question. And the bottom line is we don't actually have any evidence that adding a second drug actually decreases the likelihood or delays the development of resistance to the first one. What it probably does do is it increases the side effect profile and actually may take a patient who's really benefiting from treatment with minimal side effects and make them a patient who continues to benefit from treatment but is more miserable now because of all the treatment effects. So I think one has to be very careful about simply adding a drug with an optimistic view that it will do something that it's actually not proven to do. We tend to try and do things one at a time because remember, you saw those graphs I showed you. We have decades along the bottom. Our goal is to have this process go for decades. This is like playing cards. If you've got an ace in your hand and you've also got a jack, you don't just play them both all the time. You use them at the times to win the hand. And so you really want to not blow all your options right away when there's no clear evidence one's going to do better than the two together.
Okay, thank you. Yeah, I like that card playing analogy. I'll have to remember.
I'm not a great card player, so you can take me on anytime, Pete.
Okay. Next question is, what should be done if the bendamustine or toxin treatment can't be finished when dealing with prolonged neutropenia?
Yeah, again, good question. And in general, there's two ways in which you approach this. The first is, how well is the treatment working against the disease? So if you went, my protein started at 6,000, you're now down at 1,500 after 3 rounds, but your counts are low, I would call that done. I would just wait and see what happens, because interestingly, most patients continue to benefit over time, and you could say, that's fantastic. That's a very nice result. On the other hand, sometimes people may have low blood counts, and the problem is actually the disease is not responding. And most of what's going on is the bone marrow has lots of replacement by this lymphoplasmacytic lymphoma. And so repeating a set of tests, including a bone marrow test, may be needed to just prove whether or not the disease is benefiting from treatment. That may require a treatment to be switched to something else, like a BTK inhibitor. That's less usual. That's not as common.
Okay, thank you. I think we have enough time now for, we're almost out of time, but we have time for a final question. It's related to one of the questions that were on the slide, so I'm going to kind of jump ahead a little bit. But do you see, like right now, for many people, ibrutinib is kind of the go-to inhibitor out of all the novel agents that are out there? I know we're having a novel treatment presentation later, but in your opinion, is there an inhibitor that's kind of very exciting and will probably be the go-to rather than ibrutinib?
So I think that's a good question. My sense is that we are blessed now with at least 3 and more coming BTK inhibitors. And so we're going to be able to select between them based on potential side effect differences. So already we have Ibrutinib, we have Xanabrutinib, we have Acalabrutinib, but there are more coming. So I think when all is said and done, we will select between one of those in the group, and that may differ quite a lot based on the patient and the treating provider. There's another group of treatments that are coming that are new, and that's these BCL2 molecules. So this is Venetoclax and other drugs like that, and what they're doing is they're tipping the balance between the cell survival and the cell death, tipping them in the direction of dying like they're supposed to. And the reason I think this is important is they're good on their own, but if we compare this to the Waldenstroms to other diseases like CLL, they've been used together in CLL, and the efficacy has become even greater, and the potential for actually limiting how long you have to be on treatment is also greater. That's not been tested yet in Waldenstroms, but I see that happening down the road.
Great, thank you. Thank you. Thank you for all of your answers to all of these questions. They've been very insightful and helpful. And thank you again for volunteering your time, not only for today, but for everything you do for the IWMF and your service on the board. We appreciate everything you do on our behalf for patients around the world. So thank you again. And on behalf of the IWMF, I'd also like to extend appreciation to the Ed Forum sponsors, Beijing and Pharmacyclics Janssen, as well as our other Ed Forum sponsors, Selectar Biosciences, the Treadway Foundation, and X4 Pharmaceuticals. We're also grateful to those of you in the audience, everyone, for being with us today, for listening in and watching the presentations. Please take a moment to complete our post-event survey that'll appear on your screen once this is over. Our next presentation will begin after a short break at 1 p.m. And to join the next session, just return to the program page and click the join button. So again, thank you everyone for participating. Thank you, Dr. Ansell, for your insightful presentation on current treatment options.
Thanks.